So I'll be talking about orbicularis myectomy for refractory essential blepharospasm. A very good morning to all the chairpersons and moderators. Thank you for having me. So the role of botulinum toxin in benign essential blepharospasm is well documented, with as many as 86% of all blepharospasm patients who get controlled with the use of botulinum toxin alone. And the duration of its effect has been found to range between 1 to 6 months. However, some patients do not respond well to botulinum toxin or do not tolerate it or become refractory to it. So for this, orbicularis myectomy is done and has been reported to have a 2-year success rate of 46%. This success is based on subjective benefit, increased efficacy of the toxin injections after surgery, and longer lasting effects after myectomy. So severe disability from blepharospasm, those who had that, they benefited more. The aim of our study was to describe the treatment of severe refractory blepharospasm, which was insufficiently relieved by botulinum toxins, by doing an upper lid orbicularis myectomy and myotomy of the corrugator and the procerus, with or without a limited blepharoplasty and attachment. So we had 24 eyes of 12 patients who underwent surgery between 2008 and 2009. Outcome measure control of blepharospasm and adverse events. So we found this to be the effect of the myotomy. So a patient who had severe blepharospasm, which poorly responded to botulinum toxin before treatment, and after treatment, they were doing well. And in this variant, which had apraxia of eyelid opening, in pre-treatment, the patient is unable to initiate eyelid opening, whereas after myectomy, they are able to open their eyelids well. So 12 out of 12 of the patients were unable to perform their daily activities, and 11 of them went back to performing their daily activities with ease. None of them had control with botulinum toxin, whereas 8 out of 12 of them were controlled with chemodenervation. 2 of them needed up to 100 units for control of benign essential blepharospasm, and the dosage was down to 40 units in all and 20 units in one of the patients. 5 of the patients had effects lasting only for 2 to 3 weeks after injections. They developed a longer duration of effect lasting from 3 to 4 months. And 3 of them did not require botulinum toxin injections at all after surgery. None of the eyes developed lymphedema. 1 eye developed hematoma and entropion, which was corrected later, and another developed lag of thalmus, which resolved. Some of them had additional features like brow ptosis, dermatochalasis, and ptosis, which needed to be addressed at the time of surgery. So prior to surgery, an injection was done, 10 ml in each eye, which was modified Klein solution, which is one of the solutions which is used commonly for liposuction. So 10 ml was injected in each eye to create a good intumescent anesthesia. A strip of skin orbicularis was removed, and that was the limited blepharoplasty which was done. Following this, the preseptal orbicularis was excised. Here we can see the monopolar cautery being used to excise the preseptal orbicularis. So the end point was the translucent appearance of the skin. Now, pretarsal orbicularis was excised in a limited fashion, and a strip was left near the ciliary margin so as to avoid any lymphedema after the surgery. And the myotomy of the procerus and corrugator was done subsequently to help with that part of the action as well. Now, we found myectomy technique provides an effective treatment for refractory essential blepharospasm with a good outcome. So we know that it is an option in treating severe refractory essential blepharospasm and can be used to decrease the dosage. What this study adds is that with this possibly largest series of myectomy in India, we quantified the decrease in botulinum toxin dosage and increase in the spasm-free interval. And in future, it would be worthwhile to probably create a quality of life questionnaire to compare the botulinum toxin and orbicularis oculi myectomy. Thank you.
I have a quick question, Rwituja. Good presentation.
Yes.
How many times was Botox given and at what interval before you concluded, well, they're not responding to Botox and they'll need the myectomy and the myotomy? Did you get my question?
So, ma'am, as I mentioned in the first, I got that, ma'am. So, generally in patients which 1 to 6 months is the effect of botulinum toxin. So, anyone who had 3 consecutive, at least, episodes where they required it sooner than 1 month, we concluded that they were refractory to botulinum toxin. Less than 1 month. I can't hear you.
That enough dosage of the medicine was, the Botox was given? Was enough dosage of Botox given?
Pardon, ma'am?
Was enough dosage of Botox?
Yes, ma'am. So, yes, ma'am. So some of them up to 100 units we've tried before actually proceeding or counseling for myectomy.
So 100 units, which didn't work out within a month's time, you went ahead with the surgery?
Yes, ma'am.
Okay.
And even less in some patients who sort of were really,
Sorry
because
to interrupt, ma'am, the time is up.
apraxia,